Let's go with Team 13, if we have representatives from Team 13 to answer number 10. So we want to know what other labs would you want to order per the NCCN guidelines, kind of evaluating his anemia, and then also what grade would you assign his anemia?
Give me 1 second to pull that up.
Oh, sure, no problem.
So the lab we want is the iron, ferritin, and vitamin B12.
Mm-hmm.
And the grade, we put grade 2 for moderate because it's around 8 to 10.
Mm-hmm. That's awesome. Exactly. So here, I'm going to undo this to show you what my... All right, so I want to know total iron binding capacity, right? Ferritin, serum iron, PSAT, and B12. Exactly. Now, why do we want to evaluate that when he presents with anemia? Same team.
I guess we want to make sure if, all the, I guess we want to make sure if he really having anemia or not. So just to
it's to also confirm that it's not those issues.
Right, exactly. So it's kind of an amalgamation of what you're both saying. So we know that he's anemic based on his hemoglobin, right? Okay. So he's anemic, and we know that he's on chemotherapy, and he's, that's probably one of the reasons why his hemoglobin is so low. But the other thing that we want to know is if there's anything contributing to the anemia. So if he does have iron deficiency anemia on top of the chemotherapy-induced anemia, we want to get a sense of if we need to give him iron repletion therapies as well, right? Because we don't want to just try and correct for something, but we're not really correcting the underlying cause. Awesome. All right, cool. Yep, and it's grade 2 or moderate based on the NCI guidelines. Oops. Dang it. I scrolled too fast. Okay. I'm sure you all read that, but anyway, Team 12. All right, so should we recommend a blood transfusion or ESAs to his oncologist? And please tell me why.
We said to recommend a blood transfusion because Michael is symptomatic and his hemoglobin is 9.
Exactly.
But then we also talked about possibly just monitoring him and then changing the regimen to an ESA later down the road if his symptoms are alleviated or if the hemoglobin goes up.
Yeah, I think that's reasonable. So a couple of things. One, his hemoglobin is low. Right? Yeah, go ahead.
That wasn't me.
Oh, okay. That was somebody.
Oh, sorry, I had a quick question.
Yeah, go for it.
When you're approaching the anemia evaluation, basically evaluating the patient, you were talking about morphological and the kinetic, what you look at. What are the labs that you want to look under those?
Yeah, so we would just do
that a little bit.
Yeah, so really what we would do is I was trying to explain to you kind of what a pathologist would look at under the microscope. So we do a blood smear. And we'd look at the shape, the size of the red blood cells, figure out if they're macrocytic, microcytic, and then also trying to assess that reticulocyte index and some of the ratios, just to make sure that we're getting a full sense of is this because of decreased red blood cell production? Is it because of increased destruction? Is there an underlying blood loss that's going on? So, the reason why I kind of covered that in those couple of slides was really just to give you a sense of kind of how we look at a patient's whole picture for anemia. When someone's hemoglobin drops, I don't just look at their hemoglobin. That's obviously a really important indicator and it's the one that we're probably going to make a decision about how to dose or, what we're going to do. But in terms of long-term management strategies and also figuring out, if we might need to consider dose reducing their chemo or giving them iron, replacement strategies, things like that, it helps to have the whole picture. So really what I wanted you to get away from that is we don't just look at one snapshot. We try and figure out what the underlying cause is, and then we make adjustments for the patient based on that. And that if we take one, like if we do just kinetic or just morphologic, we might miss, again, that kind of complete picture. Most people don't do just kinetic. They'll do either just morphologic or they'll do both. And the NCCN guidelines recommend that we look at both.
What I kind of got out of the kinetic slide was that it helps you determine if you have blood loss due to some kind of hemorrhage.
Yes.
Or if there's some other deficiency that you can basically go tackle that and see why it's causing that. That's what I got out of that slide.
Yep, that's exactly what I wanted you to get out of that. Because the other piece of this is sometimes your patients, even though we hope that patients are honest with us, a lot of patients who have like head and neck cancers, for example, do tend to either have current alcoholism issues or maybe previous issues with alcoholism. And so also doing that evaluation is really helpful in figuring out if somebody maybe is struggling with that again. Especially if, we ask, but the patient says, no, I'm not, but I can smell it on them. And that happens quite a bit. So it makes it a little bit, I'm able to be more informed and say, okay, I'm going to actually give them folate too, or folic acid, and I'm going to make sure that I give them vitamin B12 supplementation as well. So yeah, but that's exactly what I wanted you to get out of that. That's great. Yay. Okay. So a couple things. One, he absolutely needs a blood transfusion. His hemoglobin is 9. He's older. He's at risk for developing, potentially acute cardiac or acute heart failure. What becomes, we'll kind of move on to the ESA discussion after that. But what we know is, bottom line, if you're symptomatic or you have a high risk of having you have a comorbidity that puts you in a high risk category and you're anemic, we're going to give you a blood transfusion. If you refuse blood transfusions, we're either going to watch and wait, although that's probably not great, or we're going to just go ahead and start an ESA. So does everybody feel comfortable with that question? Cool. All right. Let me see if I can. So for this one, I just wanted you guys to go into the guidelines and kind of just make a decision. It doesn't really matter what we choose. So I was talking to one of your classmates about this, and I was asked, well, how do you know, do you do the weekly dosing or every other day or, every 3 weeks? And the answer is really based on patient preference and also insurance preference, and also chair time. So a patient who has transportation issues, we're probably going to want to have them come back every 3 weeks instead of every week. And in that case, I'll choose Aranesp. I generally don't do the every other day dosing or the 3 day a week dosing with EPO, because that's a pain for patients. So normally I'll either do the weekly or I'll switch them to Aranesp. I don't like having patients on Aranesp because then I feel like we're going too long in between monitoring them. But the problem is with Aranesp, you're only doing maybe 1 blood draw or 2 blood draws in between. If you give weekly EPO, you got to check their blood, their blood draws once a week, right? To make sure that you're dosing properly. The problem with that is, what did I say about frequent blood draws? It causes more anemia, right? So especially in a patient who doesn't want blood products, maybe Aranesp is going to be a better choice for them, because then I can check their blood every 3 weeks instead of doing once a week draws. So that's kind of how the thought process that I walk through with that. And then again, it's going to be up to the insurance company. So when you submit the prior authorization, they'll normally tell you what's on their formulary and what they approve for what indication. All right. So And then in terms of team 11, how should we monitor for response for each of the agents? It's really kind of the same response for each agent.
It kicked me out of Teams, but from what I remember, it was once weekly.
Mm-hmm. Yeah, so when we usually start a patient, even if they're on Aranesp, we want to see how they're responding. So it's not uncommon for us to check them weekly, especially with the, Redacrit or EPO. And then one of the things we want to look for, right, is how quickly they're responding and also if they're not responding. So in that table, I'm going to jump off of this for a second. And I'm going to open up my lecture quickly because I got a question about what you guys need to know. So I want to make sure that I make it clear. Okay. Share screen. All right, here we go. Okay, so hopefully you can see this box. So really what I want you to know is, can you see my cursor moving around? Yes? Okay, good. I really want you to know this, and I want you to know this under here about what no response is. The reason why I want you to know that is because as a pharmacist, this is going to be the most important thing for you to know. The dosing, anybody can look up, right? So I know initially I said, I want you to know the titration schedule for no response. Just focus on titration for response in this box and then just down here. Because those are the kinds of questions you're going to get from nurses, from physicians, from patients, right? Because they can look up the dosing in micromedics, and frankly, so can you. So is that fair? Okay. All right. And then I'm going to share this again. Sorry, toggling between screens here. All right. So what potential ADRs do we want Michael to be concerned about from team 11? Especially given his age.
Cardiovascular?
Exactly. So specifically, what does that mean? I know what that means. I just want to make sure that.
A hypertension.
Exactly. Hypertension, which is very
the
common. MI, right? And what other kinds of thromboembolic events could patients have?
DBP, stroke.
Exactly. Those are really kind of the major ones. And those are the ones for which we had an ESA program, right? The Reprise program. So this should get us to the next. Okay, so this is a tough question. So what I want to do, first of all, I know this is a little bit hard on this screen here. But how many groups think that the FDA was reasonable for removing the REMS program for the ESAs? Do you guys think that was a good idea? I see some shaking heads. Pharmacists are so risk averse. No, yeah, I'm really torn about this. So do you think that ESAs are generally safe? I mean, if you're not really feeling like, or you're ambivalent about them removing the REMS program, does that mean that you think that they're generally safe? How about team 10?
We said we didn't think they were generally safe. I actually looked up the FDA website to see when they removed it in 2017. Mm-hmm. And so it basically says that they removed it, but with the understanding that the doctors are still going to be able to tell the patients about the risks and the survival rate, which I don't know how often that would happen if a physician prescribes an ESA, because prior to that, with the REMS program, they'd have to notify the patient. The patient has to like sign a document saying that they do know. But now that you've taken that away, they basically are leaving it to the physician to make it still known to the patient. So we said that they weren't generally safe, knowing what we know about like the risk factors that they could have. So you'd have to be monitoring hemoglobin levels to make sure that the patient doesn't go into like have a thrombotic risk.
Exactly. So, you bring up a really good point. In the absence of a requirement, how many physicians do you think are really giving patients the full, perspective on the risks? It doesn't happen very often. And in part, a lot of physicians are afraid that if they tell patients all the risk factors or all the potential risks associated with the drug, that they won't take it. But in my mind, ethically, it's still a choice, right? The patient has a right to refuse therapy, and a patient can't have informed consent if they're not informed. So this is kind of a major topic, and one that we're going to talk about in our final class where we discuss ethical considerations. And this is kind of one of the areas we're going to talk about, like how much information is too much? Is there such a thing? Especially when you're having someone submit to things that could potentially kill them or make their cancer worse. So along those lines, and thank you, Karen, for that. That was awesome. Along those lines, when you guys looked at answering this question, do you think that there is enough evidence saying that ESAs really do increase tumor progression? Do you feel like categorically we can say yes or no, or is there still gray area? So let's go for Team 9.
When I was looking up research or studies for it, it was kind of like a gray area per se, because it's like they were saying they were trying to determine like if there's any like EPO receptors on cells, and they have like different pathways they need to find out, and the results have been poor or hard to obtain for those studies.
Right. The other thing to consider is that over the last, probably 7 or 8 years, maybe longer, we've been reserving EPO and DARBA for patients who are metastatic, right, or receiving palliative treatment. We know that those patients are going to get worse anyway. So unfortunately, the deck is kind of stacked against ESAs, because how do you determine that someone's cancer is causing progression versus their adjunct therapy like EPO or any kind of ESA? So it's really hard. I mean, I think gut instinct wise, based on a lack of available information, which unfortunately as an oncology pharmacist, I live in the gray area all the time. It's very uncomfortable, especially when patients are asking me, well, what do you think? I don't ever like to respond to somebody with how I feel or what do I think, because I want to know. But this is an area that we just don't have a lot of good information. So the rule of thumb, which is a reasonable one, and what I really want you to take away from this, for patients who have like chronic kidney disease, we know, right? We know that eventually they're already dealing with hypertension. They're already being medicated to deal with potential thrombotic events. Ideally, they'll eventually get a transplant if they're eligible, and then hopefully they're not dealing with this anymore. Cancer patients are in a very different space, because we have some patients who we're going after curative intent. For those patients, unless they are absolutely going to refuse blood products, we want to avoid ESAs at all costs. When you're in the metastatic setting, even if your disease is pretty stable, we're going to try and make sure that someone is as comfortable as possible for as long as possible. And so in that case, we're going to probably couple transfusions when they need them, as well as, kind of continuous ESAs as necessary for their continuing chemotherapy. So that kind of encompasses everything for chemo-induced anemia. How do you guys feel about it? Did you enjoy this topic? Yeah, it's pretty fun. I mean, of course I'm going to say that. But one of the things I like about this is, as a pharmacist, the things that we're going to be asked about most are ESA use and also dealing with anemia, right? So this is just kind of standard supportive care. And also for those of you who are in the community and decide to continue on community pharmacy practice, you may give out or you may dispense ESA products for patients to use at home. So I hope that this gives you a better understanding of, what kinds of things we worry about when we're dispensing them to cancer patients. And, if you have a patient who comes up to you and says, I've been using my Procrit that you gave me, but my hemoglobin's still not going up, then you can start asking questions like, oh, well, have they checked your iron? Have they changed your dose? All kinds of things. And then you can potentially intervene by calling the oncologist. So, I want to empower you to feel like, even if you're not necessarily considering yourself an oncology specialist, to be able to have a cogent conversation with clinicians so that you are part of patient care. So with that, unless there are any other questions, I would love to let you guys out an hour early. It would please me greatly to give you some time back so you can study. Is that okay with everyone, or are you desperate for more information? No. Okay, awesome. All right. Well, happy birthday, Pinkle. I hope you enjoy it, and I hope you get fed good food. And yeah, and for the rest of you, tomorrow will be co-hosted by Dr. Fox and myself. We're kind of ridiculous when we get into a room together, virtual or otherwise. So expect many hijinks and lots of laughing and swearing. Hopefully no crying. And if you have any questions, just let me know. And then I extended the application. I don't know that a week is enough time for people. So I'm just going to extend the applications for like a week or two, whatever, for you to submit them. If you forget to submit them, just send them to me. It's not the end of the world. I truly could give less than two shits about it. So I just want you to do them. I want you to learn. And if you need a little more time, that's okay. There's no problem with that. I just want you to feel comfortable with it. I will post the answer key to this one. I didn't fill in some of the other stuff because I think we kind of walked through it and hopefully you guys understand it. But otherwise, your application for tomorrow, the neutropenia one's available. The rBAT should be available as well. And if you have any problems, let me know.
Thank you.
Yay. All right. Bye, guys.
Thank you. Bye.
Adios.
Thank you.
All right.